Well, I'd like to say welcome to everybody to the first of 6 webinars that the Child and Adolescent Bipolar Foundation is presenting that was made possible by a grant from the American College of Neuropsychopharmacology. I'm the program manager for CABF, and I will be moderating today's webinar. Joining me are Shira Rader, our online communications manager for CABF, and Julia Small, our assistant team leader with CABF. Shira will be available to assist with any technical issues that you might have relating to the webinar, and Julia will be triaging and screening your questions for our guest, Dr. John March. Before I introduce Dr. March, I would like to go through a few housekeeping items. First of all, we will be recording this webinar, and it will be available on our website in the chat and webinar section within a couple of days. So if you have to leave early or you come in late, which you won't know obviously, but it will be available in its entirety. All of our attendees are muted during the program. This is to prevent any background noise or feedback from your microphones. You will be able to submit questions throughout the presentation through the chat or question box near the bottom on the right-hand side of your screen. So you can open it by clicking the plus sign, and then you'll see a box where you can enter in your question. And we will respond to those either in writing privately to you, or if it's a question for Dr. March, we'll be stopping periodically throughout his presentation at the end of each section, and we'll try to field a few questions at that point. And now, I guess I would like to start our program. We're very honored to have Dr. John March with us today, as I mentioned, thanks to the grant from the American College of Neuropsychopharmacology. Dr. March is a professor of psychiatry and the chief of child and adolescent psychiatry at Duke University Medical Center. Though based formally in the Department of Psychiatry and Behavioral Sciences, Dr. March also holds faculty appointments at the Duke Clinical Research Institute and in the Department of Psychology, Social and Health Sciences. Dr. March received a BA from the University of California at Riverside and an MS in molecular biology from the University of California at Berkeley. He obtained an MD-MPH in epidemiology from the UCLA School of Medicine and is also trained in general and child-adolescent psychiatry at the Department of Psychiatry at the University of Wisconsin-Madison. And you can read more about Dr. March's extensive experience in research and training if you click on any of the links in the promotional materials that we sent to you. Dr. March also has an extensive experience developing and testing the efficacy and effectiveness of cognitive behavioral and pharmacological treatments for pediatric mental disorders. In addition to published and ongoing research, Dr. March is active in teaching and training in the treatment of child and adolescent mental disorders locally, nationwide, and internationally. So obviously with that level of experience, we are very thrilled to have someone with his expertise here to share it with you. So without further ado, I am going to turn the microphone and virtual podium over to Dr. March.
Hello, everybody. It's a true pleasure to be here. I remember actually being around at the time when the Child and Adolescent Bipolar Foundation got started, and to have participated a bit in the work of the foundation, and like advocacy groups, and really believe that if you look at the way that the field is trending, a conjunction of advocacy organizations and their foundation for philanthropy skills and activities with academic health centers, researchers who work in academic laboratories, the NIH and our colleagues in the pharmaceutical industry, particularly on the small pharma and biotech side, are really going to drive the field forward toward cures for the disorders that we treat. And you can see it happening already in the Juvenile Diabetes Foundation and the Multiple Sclerosis Foundation, in several other areas outside of neurosciences medicine. And so it's a real pleasure to have a chance to talk with folks from the Child and Adolescent Bipolar Foundation about this pivot away from treatments that we use now, which are largely palliative, toward treatments that are potentially curative, and even better than that, treatments which can preempt disease before it begins. So that'll be our topic today, is the pivot to preemptive interventions in psychiatry. It's a vision talk, a futures talk. There won't be very much in it that's clinical, but it will lay out for you a kind of roadmap for where the field will be headed over the next decade and beyond, as we begin to move more into the molecular age of neurosciences medicine. Now, I have a lot of relationships with the pharmaceutical industry. As you can see from this disclosure list, I have federal funding from NIH and NIDA, as well as a distinguished senior investigator award from NORSAD. And the important point for you to know is that I haven't done any promotional work with industry for over 15 years. Early in the mid-1990s, I decided that it was, from my point of view, unethical to work with the pharmaceutical industry in a promotional context. On the other hand, it's absolutely critical to our success as a field that we collaborate with industry in a science sense. So these collaborations that I have listed here and others that I have, but for which I'm not receiving any research or consultation support, are all science-side collaborations. Now, if you look at the kind of grand design for all of medicine, the idea is to move from palliative treatments to potentially curative treatments, and eventually to preemptive, personalized treatment. So you see that on this slide with a gene chip. I think this is actually the MAMA chip, which is used for staging breast cancer, so that we can begin to predict which treatments for a patient with breast cancer will be effective, and also to stay away from which treatments might be harmful. And ultimately, this ability to predict for subgroups of patients will get sophisticated enough that we are actually able to say for individual patients which treatment for a disease would be better for you and which treatment you should never get. And when we get to this transition from what's called stratified or predictive medicine to personalized medicine, we'll understand enough about the fundamental biology of the illnesses that we treat to begin to develop preemptive treatments, that is, treatments which are intended to stop disease before it starts. So this is the grand challenge, not only of neurosciences medicine, but for all of the diseases that we treat within a medical framework. So what I'd like to do is to talk with you about how this is going to unfold, beginning with a definition of preemptive medicine, defining what we mean by preemptive treatments, and then talking about the four pivots that have to happen for us to develop cures and ultimately preemptive treatments for psychiatric disorders. And there are four pivots which are underway and will unfold over the next several decades. The first is a pivot away from thinking about mental illness as disorders of adults. And this pivot is largely being driven by translational developmental neuroscience. The second pivot is essentially a pivot to biomarkers. So if you think about what is happening with cancer, they're beginning to develop targeted treatments that actually pick out or single out a particular protein that is mutated in a particular cancer, say the BRAF protein in melanoma, and target that protein with a very specific either small molecule or antibody that can then stop cancer in its tracks. And this idea of understanding enough about the molecular machinery for neuroscience diseases, particularly psychiatric diseases, will allow us then to develop very specific treatments that target the pathways that are involved in these illnesses, and in targeting them to cure them and ultimately to prevent them. And biomarkers are essentially the molecular diagnostic tools that we use that we'll use in the future, and I'll explain what I mean by that when we get there. Now, what this will do, this kind of improvement in the fundamental understanding of the biology of the illness from a molecular point of view, will allow us then to develop these new targeted interventions that are personalized, that are specific to the kind of biology of your illness. Breast cancer, for example, is probably 500 different diseases. It's quite likely that bipolar illness will be at least 500 different diseases. And this movement to novel interventions that uniquely target each of these diseases is the movement away from what we've been doing for the last 20 years toward novel interventions. And finally, we'll talk a little bit about how we scale this up so that instead of having clinical trials with a few hundred patients, we'll move to clinical trials that are truly preventive, that will have tens of thousands of patients enrolled, much like the big megatrials in cardiology, and in which all of our data, our complete genomes and all of our health data and all the data on people who look like us and don't look like us will be in these very large data repositories. And this will really generate the kind of information that we need to do the personalization steps. So we'll talk about how these four pivots unfold, having first defined what we mean by preemptive treatments. And after each of these 5 segments, there'll be an opportunity to ask a couple of questions. So I encourage you to send your question in using the chat field. I'll try to answer 2 questions after each of these, and then if we have time at the end, we'll talk a little bit more about questions that you might have that haven't previously been answered. So the conventional way of thinking about prevention is what's called risk factor management. In the United States, the rate of bipolar illness is double the rate of a country like Denmark. The same thing is true for unipolar depression and anxiety disorders. And it's also, although not double, it's also more common to have schizophrenia in this country than it is in Denmark. And the likely culprit here is early child toxic stress. So if you're a young person during prenatal environment or in the first year or 2 of life, if you have a highly stressful environment, it alters brain development and puts you at risk for developing psychiatric diseases, especially if you have a lot of genetic vulnerability. Denmark is a much more user-friendly country for children than the United States is these days. And the result of that is that they have lower rates of mental illness. Simple things like having enough food, having good schools, having good prenatal care, having a neighborhood environment which isn't ridden with gun violence and drug abuse. These things make a huge difference in the development of healthy brains. And this kind of approach, managing risk factors, is what we typically think about as the strategies that are used in prevention. And there was a very nice report from the Institute of Medicine, which is up on this slide, Preventing Mental, Emotional, and Behavioral Disorders Among Young People, that outlines this strategy, published in 2009. That's not what I'm talking about. What I'm talking about is a preemptive approach which is based in fundamental biology. This is a quote from Tom Insel addressing the biological processes that underlie mental illness. And what he says, and what I'm talking to you about today, is that a preemptive approach promises to reduce morbidity and mortality by intervening early, before the syndrome develops. This is intervening at the level of the biology, and realigning the trajectory of development so the individual identified as at risk has the greatest opportunity for the best possible outcome. So in this context, in the context of intervening early in biology that's off the normal developmental trajectory, we can define prevention as a biologically based theory of disease. And in this case, time is absolutely essential to the disease model. If you have a youngster who has vulnerability factors for bipolar disorder, and that vulnerability is cooking away before you have the first onset of emotional dysregulation, or you have emotional dysregulation, but it hasn't reached the point where it can be labeled as a disease state. The time to intervene is early in the prodrome, or perhaps even before the prodrome gets going. So thinking in terms of developmental trajectories that begin in childhood and extend on into adulthood, a full life trajectory is really the way we need to think about disease. Having said that, we need predictive tools in the form of biomarkers or biosignatures, which, as I'll show you, are basically just biomarkers chained together, so that we can identify people who are off the normal developmental trajectory before they get sick. And having this information about the fundamental biology in the form of biomarkers, we can develop novel interventions that forestall or prevent illness. And then ultimately, because every single individual on this call, every single individual in the universe is absolutely unique. 14 billion years of evolution have produced just you. There'll never be another person who's exactly the same as you. And to capture this individual variability is essential to personalization, so we can say what will work for you and what won't work for you. And that's going to take linking together lots and lots and lots of variables, like a personal genome, from lots and lots and lots of people, tens of millions of people in these very large databases. And we'll talk about how we'll get there over the next 20 or 30 years at the very end of this talk. Now, Jane Costello, who's the head of the Center for Developmental Epidemiology here at Duke, wrote a really nice article in Frontiers in Psychiatry on the grand challenges that face child and neurodevelopmental psychiatry. And what she said, which is prescient, is that prevention and development are intimately intertwined. Only when we understand the developmental course of a symptom or disorder can we have a solid scientific underpinning for prevention. We need biologically based theories of disease. A well-defined prevention trial will implicitly or explicitly test this developmental theory of disease. And this is biology not isolated from the environment. So all these things that we talked about a moment ago in terms of risk factor prevention are interacting with the developing central nervous system. So from the brain's point of view, there's no inside and no outside. It's all mechanism. So when we talk about a fundamental biological theory of disease, say for bipolar illness onsetting in childhood, what we're really talking about is understanding how the environment interacts with these biological vulnerability factors. So, Nancy, if we have a couple of questions that arose out of this, we can talk about them before we move on to translational and developmental neuroscience.
Okay, thank you. And before I go to any questions, just for anybody who's having any difficulties with navigating this, there is a question section in your control panel that should be on the right-hand side of your screen, and there'll be a little plus sign that you can click on that will open it up and then allow you to type in your questions. So I will, looking at what we have so far, there are kind of a variety of questions that are coming in that may not be specifically to the material you've covered, but we'll try to
pick one. I'm beginning to get a little bit behind schedule. And
okay.
Let's take one quick.
Okay. Let's see. We have a question here from Sheila who asks, how does exposure therapy work for OCD, obsessive compulsive disorder, with intrusive thoughts?
So one of my hats is developing cognitive behavior therapy for kids with OCD, and this was something I did back in the middle part of the 1980s, and expanded in terms of clinical trials in the 90s and actually through this decade. In OCD, the basic problem is a breakdown in circuitry that handles automatic behaviors that are linked to things like fear of harm of loved ones. And this corticostriatal thalamocortical circuit has a broken stop signal in it. so that the behaviors, the thoughts and the behaviors happen automatically even when you don't want them. And nobody with SCD wants any of this. I never met a child with SCD, and I've treated over 1,000 of them who likes SCD one little bit. So Exposure essentially restores this stop signal by taking a child into the situation that he's worried about, and then holding him or her there until the negative affect, the fear or whatever it might be, attenuates without doing rituals, and that restores normal function of this brain circuit. It's a little like if you were afraid of heights, and you went up a ladder. The first step, you went up once and down 10 times, and then the second step, up and down 10 times, and eventually get to the top of the ladder without worrying about it. And this basic habituation property is a highly conserved function of biological systems, so that if you sit on a chair, when you first sit down, you'll feel your bottom on the chair. Within a few seconds, that sensation will go away. It's exactly that same process with some modifications, because affect is more complicated than skin sensation that is operative here.
Okay.
So maybe we can move on to translational developmental neuroscience, which is the foundation.
I actually have, sorry if I can interrupt, we have a couple other questions that are specific to some things that you have mentioned. If we could just quickly, I think they're fairly short responses. One was from Teresa, who asks, what does it mean that bipolar is 500 different diseases? You had mentioned that earlier in your presentation.
So I'm sorry, I couldn't hear the question.
Oh, it was, what does it mean that bipolar is 500 different diseases? You had made the analogy of breast cancer being a multitude of different diseases.
So imagine that that bipolar disorder has a strong genetic component, and you all know that it's highly hereditable. Now imagine that there's, say, a dozen different gene variations that are common in people who have bipolar illness. It would be lovely if that's all that there was, but it turns out with bipolar disorder, with autism, with schizophrenia, all the diseases which have a kind of psychotic or cognitive component, that the common variants, the ones that are held in common by a lot of people, are really not what's driving the disease. What's driving the disease is rare variants. And so you may have 100 people with bipolar disorder who share one or two genes in common, but the other 5 genes that in this particular individual that are causal for bipolar illness are not held in common with any of the other 100 people that you look at. So that person has an absolutely unique disease. Now, each of these gene variants, whether they're common or rare, are on pathways that lead to affect dysregulation. And so the pathways are held in common, but let's say that you knock out a protein with phenylketonuria, PKU, and everybody's tested for that when you're born these days. That protein, phenylalanine hydroxylase, is part of a family of proteins that include tryptophan hydroxylase, which is what starts making, in the brain, starts making serotonin, and dopamine beta or tyrosine hydroxylase, which is what makes dopamine and norepinephrine. PKU has 500 different genetic variants. TPH2, which is the one for serotonin, has about a dozen identified so far. So everybody is unique, and what that means is that at the level of the individual, we all have unique diseases. We could call it bipolar given what we look at it, but if we think about how we're going to treat it, we're going to have to break it down into these unique particular characteristics, say altered proteins and so on. So with breast cancer, there are about 500 molecular variants, and it's likely that there are going to be quite a few more than that when all is said and done. And the same thing will be true for bipolar illness.
Okay, and then just real quickly, one other question that came from Liza was whether there have been any biomarkers identified for bipolar disorder.
Not at this point.
Okay.
And that's because our understanding of these illnesses is so primitive. But as I'll show you in a moment, the NIMH is basically betting the farm on biomarker strategies, and I think we're going to have enormous progress. We have enormous progress being made now, and it will really amplify over the next 5 to 10 years.
Great. All right. Thank you.
So let's talk about translational developmental neuroscience. If you ask adults when they first began to have problems or when they were first diagnosed, about 75% of them will say that their illnesses started during childhood. And if you actually get sophisticated about this and ask kids rather than grown-ups looking back in time, what you find is that you can diagnose depression, bipolar disorder, ADHD in children as young as 2 years old. That is, these disorders are present early in life. And if we have any hope at all of actually understanding what's going on with the illnesses that psychiatry and psychology treat, it means we're going to have to look into childhood rather than looking at adults who have been sick for a very long time. And the table on the left of this slide is a report from Kessler showing retrospectively in adults that these disorders, including bipolar disorder, onset early. The problem with prevention is that you have to get to people early. And in the right-hand part of this slide, there's a paper from Phil Wong, who's the deputy director of the NIMH, who shows that it takes about 10 years from the time you become symptomatic before you actually encounter the treatment system. So it just illustrates the fact that if we're going to understand psychiatric illness, we have to go much earlier down the age range, and we're going to, at the same time, have to begin to treat people when they're children if we're going to forestall lifelong chronic morbidity and mortality in adults. These are lifespan illnesses that begin very early in time. We also have a developmental progression in age, so that you see autism and ADHD starting earlier than the affective disorders and anxiety disorders, with eating disorders starting in the transition into puberty, and more typically bipolar and schizophrenia as teenagers. This slide's a bit out of date because you can actually see all these much earlier, and you can see the beginnings of them even earlier than that. But there's a developmental progression that we have to understand. For example, we have to understand what is it about the pubertal transition that leads to affective instability and the onset of bipolar illness and unipolar depression. Now, this slide shows the brain changes that are associated with development. This is work from Judy Rappaport's group, and in particular, data gathered by Jay Geed, who was a student of mine here in the early 1990s. And what you're looking at is a change in gray matter on the surface of the brain. And on the left-hand side of each of these rows is the 5-year-old brain, and on the right-hand side is the 22-year-old brain. And you can see that you start out with yellow, which is not very much thickness, and you go all the way to blue, which is a lot of thickness up here at the top. So this is the normal progression of gray matter thickening, which is associated with maturation, cortical maturation in healthy kids. This is childhood onset schizophrenia. So not only do you not have this normal progression of cortical thickening that's associated with all the kinds of things that we think of as growing up, the brain actually disintegrates. So all this red and purple in here is neurodegeneration, where you're actually losing cells. The cortex is thinning out. And this process, which begins quite early, even before you have frank onset of psychosis, is what's going to have to be blocked if we're to cure schizophrenia. We can't treat someone after they've had 2 or 3 psychotic episodes and they're at this stage on the right. We have to get them back here in order to forestall this, because once you're in this situation, it's actually very hard to reverse this damage. Now, in bipolar illness, it's not so clear. You have a progression of gray matter thickening, but it's clearly not at the same level that you'd like to see in healthy brains. So there is an interference with development. But what's really going on is in this little part of the brain down here where the arrow is, which is the anterior temporal lobe, and where the amygdala rests. And it's this dysfunction and the connection between the prefrontal cortex up here, oops, got to go backwards, up here, and this part of the brain that regulates feeling, the anterior temporal lobe, that's broken in bipolar illness. And you can see this more clearly in this movie that actually maps this progression. So if you look at the increasing levels of blue, moving from a child who's prepubertal to postpubertal and has developed bipolar illness during this period of time, what you want to look at is this blue right here, which right now is actually already blue in a 7-year-old. And what you have actually is accelerated cortical development in the circuits that regulate affect, because there's so much affective dysregulation. It's actually causing this circuit to hypertrophy, to be on overdrive. So unlike schizophrenia, which is primarily neurodegeneration, there's some of that in bipolar illness, you've also got circuits which are amplified inappropriately. And it's trying to understand this process across time that we call translational developmental neuroscience. Here's an example from a disease we typically think of older people, Alzheimer's disease. So this is a model of Alzheimer's across time. Somebody's born, they have normal development, they live a long life, and they get to be my age, and you begin to have problems with memory. And that's normal for seniors, but for some people it's accelerated. And in folks who have particularly a risk gene called ApoE4, you have this accelerated decline in cognitive functions that eventually leads to death from Alzheimer's. Well, it turns out, if you look at the teenage brain, that if you have this risk allele, you actually have the damage that's associated eventually with Alzheimer's starting very early in life in a little structure called the entorhinal cortex, which is, you see the arrow, which is right here. And this is an area which sort of feeds the information to the memory circuitry. This is normal thickness of the entorhinal cortex in healthies. This is people who are heterozygous. They have one copy of the bad ApoE4 gene. And this is teenagers who have 2 copies that have less brain matter in the entorhinal cortex. So the damage is actually starting back here, even though the disease doesn't start till here. So if we're going to prevent Alzheimer's disease, it's going to have to actually get going early in life, not in older patients. And that's true for all of the disorders that we treat. And you can see that in this in this slide. Here's birth, normal development. There's some sort of insult that happens against a background of genetic vulnerability. You can continue on and look pretty normal for a while, and then all of a sudden, as a teenager, you can get sick, or you can begin to fall off the developmental trajectory earlier. But at some point, you get far enough out so that you don't look like normal anymore, and you get a diagnosis. And our job is to understand this process so that we can return kids to a typical rather than atypical developmental trajectory.
Dr. March, if I could interrupt for just one moment. We're getting a few comments from people that are having a little trouble hearing. So I don't know if there's anything you can do to adjust your phone. It's coming through okay for me, but I think it depends on different people's setups on their computer.
Yeah, I don't think there's actually anything that I can do to make that better on my end. I'm sorry for that.
Okay, I'll suggest to our audience that you try closing out any other applications that you may have open on your computer. So that might help as well, and obviously turn up the volume on your speakers or your headphones. So thanks. Sorry for the interruption.
So the NIMH recognized that that the future of research in mental illness was going to shift from adults to children. And Pat Levitt, who's a basic and translational neuroscientist, and I chaired a work group for the National Advisory Mental Health Council on the importance of translational developmental neuroscience. And that was published in 2008. And essentially it's guided the NIMH in shifting resources away from the biology of adults toward the biology of developing organisms, whether they're flies, fish, mice, or developing children. And you can actually see the impact of this in the kinds of studies that are now being conducted by the NIMH. There's a lot more developmental neuroscience that's happening now, and it's shedding all kinds of light on the origins of these illnesses. Now, maybe we can take one or two questions quickly on translational developmental neuroscience.
Okay, yeah, I'm going to combine two together here. We have a question about whether there's a test to prove bipolar in regards to a brain scan, and I think this came from the pictures that you showed with the different colors on the brain development. And related to that, if you can comment on the use of SPECT scans as well.
On the use of what kind of scan?
Of SPECT, S-P-E-C-T.
Sure. So right now, imaging tools, whether they're MRI or PET or SPECT, or the tools that are related to quantitative electroencephalography, EEG tools, all of these are research tools at this point. None of them are actually useful for clinical prediction. People use SPECT for clinical prediction, but most people who do research in this area don't believe that this is ready for translation into clinical practice. And the reason for that is that it's just not accurate enough. So if you're 90% right in saying that somebody has an illness, you miss 10% of the cases. And if you're 90% sure that somebody doesn't have the illness, then you've labeled 10% of people as having the illness who don't have it. And that's pretty good, 90% accuracy, positive and negative, but it's not good enough for clinical care. So I would say for myself that that we're not ready to do this translation out of the laboratory and into clinical practice for any of the imaging tools. It's really a very immature science at this point, with the exception for PET biomarkers for Alzheimer's, which I'll talk about in just a moment, to kind of show us the way forward. So moving now into biomarkers in personalized medicine. A biomarker is a characteristic that's objectively measured and evaluated as an indicator of normal biological processes, pathogenic or disease processes, or pharmacological responses to a therapeutic intervention. And a biosignature is just an optimized biomarker. So if you want to improve the predictive validity of a biomarker, a single gene test, for example, you chain a bunch of gene variants together, or proteins, or genes and proteins plus a scan, so that you improve the ability as a test to say that somebody, for example, has an illness or doesn't, in fact, have that illness. And if you don't have that excellent predictive validity, then these things simply can't be translated into clinical practice. Now, we use biomarkers all the time in other areas of medicine for diagnosis. For example, this is a Dynamap, a blood pressure reading device that everybody here is familiar with, for diagnosing hypertension, which is a risk factor for cardiovascular disease, and the reason that we treat hypertension, which is this biomarker. When you have a blood pressure above 140/90, we treat it aggressively so that you don't later have a heart attack. It's that kind of a model that we'll be using for biomarkers for diseases like bipolar disorder. There are also tools for staging diseases, how sick you are. So with breast cancer or other forms of cancer, you can determine whether there are metastases or how big the tumor is, whether it's with breast cancer extended into the lymph nodes. These are biomarker tools for staging disease and guiding treatment. You can look at biomarkers that tell you prognostically whether the kind of tumor that you've got is going to be nasty or not nasty. For example, if you have an estrogen receptor negative breast cancer, then you're not going to be able to use Herceptin, which is one of the new targeted treatments. And then we can use these to predict or monitor clinical response to an intervention. So if you have an elevated fasting blood sugar and it comes along with a hemoglobin A1C that's also elevated, these are markers for diabetes. And when we use insulin or diet or exercise or oral hypoglycemics to treat diabetes, we're following these markers to see if patients are responding to treatment. So you're all familiar with using biomarkers every time you get a lab test or you get a chest x-ray. And what we need to do is develop biomarkers and biosignatures that work as well for neuroscience diseases as they do in other areas of medicine. The FDA has said very clearly that biomarkers are the foundation of evidence-based medicine. Who should be treated, how, and with what. It's actually the process of understanding fundamental biology from translational developmental neuroscience is essentially a biomarker identification strategy. And absent these new markers, we're not going to be able to develop targeted therapies. The therapies that we use will be limited and treatment will remain largely guesswork. So biomarker development is really the critical piece in developing these new therapeutics. Here's a really exciting development in Alzheimer's disease. You know, like with bipolar, if you treat Alzheimer's disease late in the game when you're already pretty advanced in the sense of dementia, the same thing is true with bipolar illness. If you've had a lot of episodes of mania, it becomes harder and harder to treat successfully. So the whole field of Alzheimer's disease has needed a biomarker which could identify people on the path to Alzheimer's disease before they actually get there. And this is an imaging PET ligand for beta amyloid, the major proteomic marker for Alzheimer's disease, that distinctively labels beta amyloid, which is the main constituent of the neurofibrillary tangles in Alzheimer's disease. And you can see that there's relatively little beta amyloid deposited in a normal brain and a ton of it in the Alzheimer's brain. So what's happening in Alzheimer's now is they're looking in between these two scans for people that have mild cognitive impairment and have the beta amyloid marker identified with its radiopharmaceutical so that they can begin clinical trials in patients who are on the pathway to Alzheimer's. And we will hopefully at some point have similar, they may be MRI biomarkers or lab tests, blood tests, or tests from CSF that will allow us to do the same thing, that is, intervene early in patients who are on the way to disease but who don't yet have the disease. And what that will do is make it a lot easier to treat because a lot of the damage that comes with the progression of these diseases, like with advanced breast cancer, make intervention much more difficult. So Alzheimer's disease, even though it happens in geriatrics, is actually a wonderful model for the treatment of neurodevelopmental illnesses beginning in childhood. And anybody who's interested in this might want to take a look at this NIH consensus program for preventing Alzheimer's disease. There's a panel statement which really lays out how you think about a prevention strategy for psychiatric and neurological illnesses. And I commend this report to you because it's the model that we'll be using as we begin to intervene early in psychiatric disease. So any questions about biomarkers?
Yes, hang on a second, and I will grab one for you. We had one question about whether the symptoms of bipolar are the same as biomarkers. So I'm wondering if you could backtrack a little bit and just go over that again. It sounds like a couple people were confused with that.
Very good question. Are the symptoms of bipolar disorder biomarkers? And the answer to that question is no. And I had a very complicated slide in here to explain that. And it's actually more complicated than I want to go into now. But a biomarker is something like a gene variant or an abnormal protein or an MRI scan, which is different in somebody who has the illness as compared to somebody that doesn't have the illness. It's actually not a symptom because the symptom can be the same in lots and lots and lots of people, who have very different diseases. So the biomarker that identifies the person with, uniquely identifies a person with schizophrenia can be quite different than the biomarker that identifies a person who has bipolar illness, even though they're psychotic and hard to tell apart symptomatically. So signs and symptoms, when you look at a patient and they tell you something about themselves, which is a symptom, or you see somebody who is floridly psychotic, and you observe that, which is a sign, those are not biomarkers. Biomarkers are tests that we do which tell us something about the underlying biological processes which lead to those behavioral symptomatic disturbances.
Okay, great. And then one other question was whether people with bipolar disorder have a greater risk for illnesses like Alzheimer's, if there's any correlation.
That is a very good question, and one that I don't know the answer to. There are diseases which do carry a higher risk for Alzheimer's. Diabetes, for example, does. So if you're bipolar and you become obese and develop diabetes, that would increase your risk for Alzheimer's disease. Down syndrome has a dramatically increased risk for Alzheimer's disease. But I'm not sure about whether bipolar illness per se, other than through the fact that it's a risk factor for cardiovascular disease, which itself is a risk factor for bipolar illness. I just don't know the answer to that question. It's a really good question. I would say that Alzheimer's is a neuroinflammatory condition, and bipolar illness also involves neuroinflammatory components, and those may non-specifically increase the risk for dementia. But I doubt actually that the specific biology of Alzheimer's overlaps the specific biology of bipolar illness.
Okay, thank you.
So what does this tell us about these kind of new, promised, better treatments? And before doing that, I want to say a little bit about what's going on with the pharmaceutical industry, because everybody's freaking out about the fact that big companies are getting out of psychiatry. Lots of information in the last 2 years about how GlaxoSmithKline is pulled out of neuroscience diseases. There have been a bunch of articles. The middle one here is an article in Science about this is your brain off drugs, Life Pharma's cooling on psychiatric drugs. AstraZeneca's gotten out. Sanofi-Aventis has really restricted their work in neuroscience. So it's true that large pharma has backed away, and what that means is that most of the activity is switching to biotech and small pharma, which is where all this kind of novel fundamental biology is playing out. And large pharma is waiting around until we have a better understanding of what's going on biologically, and then they're going to license compounds or buy the small companies or some combinations of both and jump back in again. So it's not as though there's not a lot happening. It's just the frame of reference has switched. There are over 4,000 companies active in neuroscience diseases at the moment. So now, why has large pharma gotten out? It's because it's very expensive to do drug development. Right now, to take a drug from identifying a target for that drug in animal models and moving it through preclinical drug development, through phase 3 trials, and eventually FDA approval and commercial launch cost $1.8 billion in today's dollars. The entire budget of the NIMH is $1.4 billion. So that should tell you right away that the NIH is not going to be doing drug development. It's going to have to be done in industry. And this is actually much more difficult in neuroscience, particularly in psychiatry, than it is in other areas of medicine. This is a bar graph looking at new drug approvals in depression and schizophrenia versus heart disease. And you can see back in the 1950s that it was about the same. There were 2 or 3 new drug approvals in all 3 of these in a year, in all three of these conditions, depression, schizophrenia, and heart disease. Well, we're not doing much better with schizophrenia or depression, and these are mostly copycat drugs, whereas in cardiovascular disease, there's all kinds of activity. And part of the reason for that is that our biology for the diseases we treat is much more complicated The heart has 7 medical subspecialties, and it's a simpleton compared to the brain. And so it's just a hard problem, and we're now amassing the tools to take this hard problem apart, and we're going to expect that this is going to pick up as we move forward. But large pharma's basically said, I can develop drugs in other areas. It'll cost me less and be easier to do. So until things get easier, we're going to see most of the activity in small pharma and biotech. And what that means is that we're going to see a lot more what are called proof of concept trials, the big expensive phase 3 and phase 4 programs, which is why nobody's trying to enroll your kids any longer in clinical trials. So this was an article by Steve Paul in Nature Reviews Drug Discovery in 2010. And what you have in the top here is where pharma has spent its money up to now. And most of the money has been spent on big registration trials, many of which fail, and then out in phase 4, which is where all these marketing-oriented trials have taken place. Most of the money now is being spent on preclinical development and what's called proof of concept, which is where you decide whether a new molecule or a new biological treatment, like an antibody targeting a particular aberrant protein, whether it looks like it's going to make it all the way to commercial launch. So the idea is to start lots and lots of things early, winnow them out, and then take the ones that look like they're going to go forward all the way forward. And for this to happen, this step right here, this early preclinical and proof of concept strategy is explicitly, like I showed you with that FDA slide, a biomarker strategy. The NIH is also trying to do this. They've put together something called the National Center for Advancing Translational Sciences, which is to help de-risk a lot of these novel treatments, which pharma doesn't particularly want to tackle. So the NIH, as well as the NIMH, is spending a fair bit of money these days on drug development, but it's all on these novel interventions, not on current generation treatments. And last year, David Lewis, who's the chair of psychiatry at Pittsburgh at Western Psychiatric Institute and Clinics, David Lewis and I chaired another council work group called From Discovery to Cure. And what we did in this work group was lay out the same drug development pathway for the NIMH that pharma's on, that is early preclinical drug development and proof of concept studies. So if you read these two reports, one of them on translational developmental neuroscience and the other on what's going on with drug development for mental illness, you have a really good view of where the NIMH is going with respect to research. And it's basically drug development, which is going to happen based on an understanding of fundamental biology of these diseases in children. And it's a very hard problem to solve. And we're not going to see payoff for treatments for current generation adults or children, but we will see the payoff in the next 5 to 7 years with some new drugs, and we'll probably move to preemption, not in this decade, but in the next decade. Now, how does this work in terms of drug development? Well, if you look at our current medicines, actually most of them go all the way back to the chlorpromazine molecule, and which was the first antipsychotic. And what happened was somebody looked at it and said, well, actually, people aren't getting depressed when they take this medicine, and so that led to imipramine. And people said, well, there are a lot of side effects with imipramine, and we know a little bit about serotonin, and so that led to fluoxetine, the first SSRI. But this was all done based on clinical observation, exploring mechanism of action, doing some animal work, and then taking it back to humans. It's what's called serendipitous drug discovery. The new way that we're going to do drug development, which is what you see now in oncology, is to understand the genetics, which will tell us the pathways that lead to mental illness. It'll give us a good sense for what the molecular pathophysiology is. That will then identify points of leverage on these pathways that will allow us to do small molecule screening or to develop biologics like antibodies, and then take those into clinical trials. So here's how it will work. Let's say we have a neurodevelopmental disorder like autism or bipolar disorder or schizophrenia, ADHD. We'll understand the genetics, and we're only a few years away from the $500 personal genome. So it will be within the next 5 years that basically everybody on this call will be able to have their genome run from one to the other for under $500, which will really unlock the secrets of the genome. That will tell us a lot about the biology of these illnesses, because we'll really understand what the molecular pathways are, and we can drop these aberrant genes in combination into mice, into flies and cells, and really understand sort of what's going on with the biology using these model organisms, and also how these molecular events translate into aberrant neural development, aberrant plasticity, how the wiring of the brain is disturbed by these altered molecular events, and somewhere on these pathways, pathways which specify the wiring of the brain, so that the circuits that are built to do particular tasks like executive control or affect regulation don't do those tasks properly, we'll be able to identify molecular targets or structural targets for something like deep brain stimulation that we can develop better targeted treatments. In this case, on this slide, I'm running small molecules at a target to identify a new drug that will work for a developmental disorder. So this pathway, what's called reverse translation or the molecular medicine cycle, is the pathway that will drive drug development in the future. And you can already see it in Fragile X syndrome, which is a tandem repeat in the promoter region for a protein called the Fragile X mental retardation protein. And this protein, abbreviated FMRP, is a brake on the major excitatory neurotransmitter in the brain, glutamate, so that you have glutaminergic activity, excitatory activity, that is unopposed, and the FMRP brake is broken. And so neurons kind of defend themselves by altering the number of receptors, particularly receptors called AMPA and NMDA receptors. And this causes the neurons not to function properly. They look funny and they don't work. You can block this process by using a small molecule that sits on a glutamate receptor called mGluR5. And in the fly and the mouse model for Fragile X, this completely reverses the behavioral syndrome for Fragile X. The flies and the mice normalize. And STX-109, which was developed by Seaside Therapeutics, is a small molecule that is now moved into phase 3 trials in adults with Fragile X syndrome, and will soon move into kids with Fragile X syndrome. And it will potentially, in humans, reverse this disease. So this is the payoff. It's kind of the poster child for molecular medicine. And Fragile X is a lot simpler than bipolar illness, but we're going to see more and more and more of these kinds of therapeutics in the next few years. It's not just small molecules or biologics, antibodies, and so on. It's also what we typically think of as psychotherapy. So somebody asked about exposure before. Let's imagine that you could get a quantitative electroencephalographic signal for off-trajectory information processes like fear processing, someone who has a lot of anxiety. And you could train that process directly to the unique electroencephalographic signature for that individual, showing an enhanced bias toward threat cues as compared to safety signals. Well, that's actually now happening. This is an example of a child sitting in front of a tool called BrainPal, which is looking at attention and ADHD, attention and response inhibition. And this tool right here, if you use it this little game that kids play, which is, you can see the EEG cap that he's wearing. So he's running Curtis the Duck around a racetrack using just his mind. And over a period of about 12 weeks, doing this 3 times a week, it has about 2/3 the effect of a psychostimulant. And the effect endures for at least 6 months. So I think these kinds of technologies are likely to replace what we now think of as psychotherapy. But we're really altering, using plasticity-based mechanisms, altering the way the brain processes information. And then if you combine those with medications, say a small molecule therapeutic that enhances learning, normal learning, you now have a way to think about either the prevention or the rehabilitation of these diseases. So that's a really exciting future in which we actually access the brain through a whole variety of different mechanisms in a way which will return these processes toward more normal development. And we're at 2 o'clock. I know I've talked too much, actually. Are we okay if we go on for a little bit longer?
Absolutely, and you haven't talked too much, so if you have the time to continue, that'd be great. And then I just have a few questions I think that would be a good way to wrap up the presentation when you're done.
Okay. Now, everybody knows when you go to a clinic and you're sitting in the waiting room that patients with bipolar disorder aren't the same. People have different manifestations of the illness. And the question is, how do we capture that? And capture it we must if we're going to develop treatments that are uniquely suited to an individual. So I can say to you as a patient, this is a treatment that will work for you. And compared to your neighbor for whom this treatment won't work, he's going to get a treatment or she's going to get a treatment that actually you shouldn't get because it would make you sick. So getting there is going to require that we scale up into the tens of thousands of patients, even millions of patients, to capture all this variability that makes us unique as human beings. And to do that, to compare treatments so that I can say, this one you should always get and this one you should never get, and your neighbor has a different picture in terms of what treatments they should get or not get, requires that we do clinical trials in the clinic rather than in these little research trials that we've been doing for many years, and also very different in the proof of concept studies that I talked about before. So this is called comparative effectiveness research, which is the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, or monitor a clinical condition and to improve the delivery of care. And the idea here with these trials is not to say that a treatment works. It's to basically provide information that helps decision makers, like parents, for example, or their doctors, or the children that are ill themselves, or formulary benefit managers know what to do. And the side benefit of these strategies, which involve real doctors and real patients participating in clinical research, is that we can get enough patients, say, for example, with personal genomes, that we can begin to tease apart variability. Now, if you look at the global disease burden, the largest source of disease burden in the world is the collection of diseases that we treat in neurosciences medicine, basically brain disorders. And we all already know that these disorders start during childhood. So if you look at the 100 priority topics for comparative effectiveness research, neurologic disorders, psychiatric disorders, and pediatrics are right at the very tippy top of the list. And what's going to get us there in the sense of doing these kinds of what are called pragmatic trials or large cohorts or patient registries is the ability to capitalize on the electronic medical records. So imagine that you go to a doctor, and instead of having somebody advertise a clinical trial, what the doctor says, would you like to be, we don't know actually which of these 2 treatments would be best for you. There's a study that's going on that's going to enroll tens of thousands of patients comparing treatment X, which might be the new treatment, to treatment Y, which is the old treatment, And all we're going to do is what we would do anyway, which is to make a choice between these two treatments. But instead of you and I choosing based on no idea what will happen, we're going to just flip a coin, and then we're going to database the outcome. This will happen when we move away from clinical trials as they're now done as kind of one-off networks with separate databases and kind of a whole separate clinical trial structure to doing clinical trials in the context of the electronic medical record. Everything is going to get much simpler when this happens, and it's part of Obama's healthcare initiatives to help transition the field as quickly as possible to EMRs that can then be bolted together so that we can take all the data that's available for any single individual, their personal genome, all their laboratory tests, their clinical history. You're in it, your mom's in it, your uncle's in it, lots of people who look like you and don't look like you are in it, and through very sophisticated information technology and biostatistical strategies, we can begin to understand how to reason from the genome all the way up to your social environment and everything in between. And that will then let us get to personalization. So Osler pointed us in this direction many, many years ago, around the beginning of the 20th century, when he said to wrest from nature the secrets which have perplexed philosophers in all ages, to track their sources, the cause of disease, to correlate the vast stores of knowledge, that they may quickly be available for prevention and cure of disease. These are our ambitions. And for the first time in human history, the tools to do this for neuroscience diseases are becoming available. And it's a little like we've been given the Hubble telescope to look at the brain, and we've been given the tools to learn that from real people and with real doctors in real clinical settings, not in especially research settings. And the combination of these two things is really going to allow us to develop treatments which are personalized and preemptive over the next 10, 15, 20, 30 years. It's not going to be easy. It's going to take a lot of money and effort on the part of a lot of people, beginning with the sufferer community. To actually look at medicine, what we know, the whole basis of medicine is a small number of researchers and a slightly larger number of people like you who've been willing to participate in clinical research. What we're moving toward is a set of tools which will allow us to take the brain apart and put it back together again in a way that makes for better treatments, and to enable everybody to participate in this process. It's a tremendously exciting time, and the processes that are going to let us do this are already underway. So if you look at this from the point of view of where we are now, where we're headed, right now we have diagnosis by observation. People come in, they get sick, they disappear. Your doctor doesn't talk to the doctor down the street. We have no biomarkers. We're using paper records, and it's incredibly primitive. We're about to move to biomarker-driven strategies. Biomarker-driven strategies which are stratified. We can say, based on a biomarker, you belong to this group and should get this treatment, but it won't yet be personalized. On the other hand, it will treat the core of the illness, let's say affect dysregulation, rather than a treatment aimed at bipolar disorder. There'll be a cognitive treatment, an affective treatment. There'll be specific treatments for the components of the illness, and these will all be captured in the electronic medical record. Eventually, when we move to preemption, it will be personalized treatments that will pop up within the EMR so that when you go to see your doctor, he'll have access to all the available information for all the patients that are in the system, and can decide what it is you've got and what would be the best thing to do about it. And that's the strategy for the next 20 years or 30 years in neurosciences medicine. This is the website for the two National Advisory Mental Health Council reports. I don't know why Osler ended up on that slide, but if you want to go pull off from Discovery to Cure and the one on translational developmental neuroscience, you can pull them off this website. So I'm sorry that I ran over, and we still have some time for questions.
Great. Well, thank you very much. I think this offers us a great deal of hope for what's coming down the road. I have a question here, and it kind of segues into what you were talking about. We had a question from Sandra who asked if there were any opportunities for people who wish to advance the research for biomarkers to be involved in any clinical studies. I know that we routinely send people to the NIMH website. Would that be the best place, or are there other avenues that they can pursue?
The NIH has actually developed a tool for matching patients to clinical trials. And I think you can link to this off the NIMH website, but I'm not exactly sure, and I don't know to what extent the NIMH or NIDA are actually taking advantage of this. At this point, most clinical studies in real human children, are still quite small, mostly headquartered in academic medical centers. So the best way to participate is to see what's going on in your local university. The advantage to doing that is that you'll also find a subspecialty clinic, which is going to be much more up-to-date with respect to the modern evidence-based medicine than might be otherwise the case. So, like I said before, all of what we know is really a small number of researchers and a slightly larger number of patients on whom everything else depends. So participating in clinical research, whether it's an MRI study of your brain relative to kids who don't have bipolar disorder, or a biomarker study, or a clinical trial, or whatever it might be, it's really important for people to participate, because otherwise we have no ability to make progress.
Okay. And then another question was in regards to how does this actually play out in terms of application for us parents who are the end users? I know you said that this is where research is going over the next 10 or 20 or 30 years, but where does that leave us in terms of getting the right diagnosis for a child when often we don't have access to those thought leaders and experts in the medical centers? And you know, what can you offer up in way of hope to our families in terms of getting the right diagnosis for their children so that they can get as a follow-up, that they can get the right treatment?
So that's the critical question, and here's what I tell people, because that question is asked all of the time. The big problem with psychiatry and psychology and social work, people who treat patients who are mentally ill, at this point is a huge amount of heterogeneity in the field. So you find kids all the time, and they've been labeled this, they've been labeled that. They go to one doctor who said the other doctor's an idiot. And you have kids that get treated with all kinds of different things. And pretty soon you have a youngster that's on 5 drugs, and nobody knows what the hell is working or not working. And the child's getting more and more obese and sicker, not because of the illness, but because of all the treatments that we use that haven't been done well. So we don't have sort of standardization of evidence-based care in psychiatry. It's a complete hodgepodge. In some ways, it would be better off we'd all be better off if we got rid of it and started over. Those are harsh words, but what they imply is that who you have as your doctor is actually the most important decision that you'll make. What you want is a doctor who has the problem that your child has as one of the 10 things that they do every day, and they're up to date, so that what they do by way of treatment is the best of the currently available treatments. And if you combine intelligent pharmacological management with current generation treatments, with a psychosocial intervention like Dave Miklowitz's family-based treatment for bipolar disorder, and you get to the kids early, then the prognosis is actually surprisingly good. If you don't have access to these treatments and you're one of the unfortunate persons whose treatment is all pharmacologic and things are being switched around constantly and they're on 2 or 3 atypicals at the same time, and it's just not a good situation. Then you have to ask yourself the question: how do I find somebody who's going to be at the edge of the evidence-based field? And the best way to do that, if you don't live up next to an academic medical center, is to travel to one and get a consultation and make sure that the consultant for that is willing to work with your clinician locally in order to put that treatment plan in place. With respect to the psychosocial treatment, you can buy Dave Mikulitz's book, and or if it's a child with OCD, you can buy my book. Not an advertisement, but I always feel like the best way to handle this is to grow your own doctors. So you say, I can find someone in your area, or you can find someone in your area who's willing to learn and willing to try something. And you take this book in, you're the best advocate for your child. You know a lot more about your child than your doctor will know, and you can begin to implement these things. And because you've done it, then the next child that comes along will also have access to it. And pretty soon, in your community, you have a whole movement toward evidence-based specialty care that's just grown up around your kid. And I think that's probably the best way to handle it. But it begins with a specialty level consultation. And there are academic medical centers within reach of most people, within, say, 150 or 200 miles in most places of the country, that have the kind of expertise that you need. There's also a lot of information available just on the internet. But what I would say is that because kids are unique, and because we're so primitive at doing this these days, even with the best available diagnostic approaches, we're still swimming in jello with respect to what's best for the unique kid. It's still trial and error. It just needs to be done systematically. So I wish it was 30 years from now when we'll be doing a much better job, but we're simply not there yet. On the other hand, the best of the currently available treatments are certainly a whole lot better than what most kids get. So the trick is to find and get access to those evidence-based treatments that are currently available and apply them.
Great. Well, thank you very much. And just as a follow-up to that, you mentioned David Mikulitz's book, and his books are available through our bookstore at www.bpkids.org, and we'll see if we can get your book listed in there as well. And also for families who are wondering how to go about finding the right clinician, I encourage people to contact us through our family response team, and we can work with you to try to help you locate clinicians with the tools that we have available at our organization. So again, you can find that on our website if you go to bpkids.org and click on the Connect tab and then Family Response Team. So hopefully that will be helpful to our attendees here. And I want to just say a huge thank you again to Dr. March. This was incredibly interesting, enlightening, hopeful. We do have a long way to go, but there's a lot of exciting work that's being done. And we will have the full recorded webinar available hopefully later today on our website at Connect, and then click on the chat webinar link. So thank you again for everything, and we really appreciated having you spend your time and your expertise with us today.
No, it was my pleasure, and I salute all of you for being part of this. The people I worry about are not the folks that are members of the foundation or participating in this call. It's all the people who don't have access to this. So it's really wonderful that we can work together to try to make the lives of kids with bipolar illness better now and in the future. So we'll keep at it, and I'm absolutely confident that within a few years we're going to see new, novel interventions that will do a much better job for our kids than what we currently have available to us.
Great. Well, thank you, and I see a lot of thank yous coming through from our audience with great enthusiasm and exclamation marks, so I think this was a great success for everybody who was here. And wish everybody a good afternoon.
Bye, everybody.
Bye.